Welcome to the presentation on medication mismanagement. My name is Dr. Stephen Dorman and I am the Chief Compliance Officer for CCI Anesthesia. I named this presentation Medication Mismanagement because I wanted to focus on the problematic medication management issues within the practice of anesthesia. Here are my credentials. I graduated from medical school at the University of North Carolina in Chapel Hill, North Carolina. I did my residency in the Navy at NRMC, Oakland, California. After I retired from anesthesia, I became a Joint Commission surveyor and surveyed for 10 years. I then continued with a consulting business. Part of my consulting business involved drug diversion investigations. I was also survey team leader for non-long-term care surveys of CMS as Chief Medical Officer for the New Mexico Department of Health. And finally, I am the Chief Compliance Officer for CCI Anesthesia, where I have been for the past 4 years. This slide shows how problematic medication management standards can be. Joint Commission surveys according to risk and frequency. Risk, of course, takes the highest priority, so even a single medication management finding can result in a survey with an adverse outcome. CMS scores according to standard or condition level deficiency. Whether to score a finding as a standard or a condition level is certainly fairly subjective. Condition level deficiencies can result in a repeat survey and a possible termination notice to the hospital. The first and most common issue are deficiencies in documentation of controlled substance administration. Medications are removed and are not indicated as having been administered, or the totals don't match up. In any case, these, though innocent appearing and not getting much attention from staff, can result in allegations of diversion, investigations by the hospital, reports to state boards of pharmacy, and ultimately the DEA. As a result, inaccurate conclusions can be reached that can adversely affect a provider's privileges and/or medical staff membership. Another problem is improper disposal. Though we recognize that witness wasting method of control can be easily bypassed, it still remains a requirement by some hospitals, so wasting without a witness is a violation of hospital policy. The DEA requires that medications be discarded in a non-retrievable manner, so you cannot discard these medications down a sink, nor can you dispose of them in a sharps container. Special receptacles with absorbent material are now approved by the DEA for disposal. Sometimes medication waste is not recorded in an automated dispensing machine or on an anesthesia record. And finally, in an attempt not to waste drug, ketamine in multidose vials is used on several patients without precise dispensing and/or administration records. The use of multidose vials for controlled substances is to be avoided at all costs, since precise measurement of the drugs remaining in the vial is problematic, along with all the other issues related to multidose vials. So proper disposal would consist of assuring a witness is available if the policy requires it, disposal of the drug into absorbent material, or return of the unused drug to pharmacy where spot checking can be accomplished for drug in concentration, and any unopened drugs returned to storage with a patient charge credit. A drug diversion investigation would include statistical analysis of drug usage by provider. However, this type of data analysis may not be well understood by staff. Analysis of this kind of data is only valid over time, not on a day-to-day or even a week-to-week basis. In order for use analysis to be significant, longer runs of the data is required. There can be errors comparing provider to provider. An anesthesia provider doing hearts would have a much higher recorded drug use than one doing pediatrics, so providers should be compared to like practice providers. This is important not to draw the wrong conclusions from the data. Medication that is returned to pharmacy can be assayed with an optical density refractometer for drug and concentration. Investigations may also involve locker searches, which are not considered private property when inside the hospital. Even if a provider is drug tested at random, there could be allegations of theft for drug sale. Medication security is probably the number one finding after documentation. The challenge question is, can a non-licensed, unauthorized person access any medication unobserved? If the answer is yes, then there is a medication control finding. This usually occurs with medications left in or on anesthesia cards. There are situations when unlicensed but authorized individuals may access medication, such as anesthesia or pharmacy technicians, but these allowances should be contained in their job description. More medication control issues include carrying medications in clothing and transporting medications in a non-secure manner. Fanny packs are generally considered to be a decent way to transport medications, but this is highly subject to surveyor variability. We have the wearing it to the restroom problem. The beyond use parameter is an industry term for the date or time after which a medication may not be used. We sometimes call this the expiration time or date, but beyond use date is a better term. All pre-drawn medication must be labeled with a time of expiration or beyond use. If the time is actually a day, then a date is required. Most medications drawn up outside of a 797 hood generally have a 1-day beyond use date. It is not appropriate to pre-draw multiple syringes for medications of the same medicine. This is called batching and must be done under a 797 hood. I have listed the beyond use parameters for particularly time-sensitive medications. This slide deals with medication labeling. The syringe label must contain a beyond use parameter, either date or time as appropriate, the medication name, the medication concentration, and the identification of any diluent if the medication has been diluted. The best policy, of course, is to discard all syringes at the end of the case. But sometimes medications are pre-drawn for emergency situations. If this is the case, consult pharmacy on the proper beyond use parameter. Timing, of course, is critical for propofol, and surveyors are aware of this. I was in a cardiac operating room where the temperature was so cold that it was below the proper storage temperature for the medications that were in the room. Here you will see the required parameters for a proper syringe label. The date and time the medication was prepared is not required and is actually moot. However, the beyond use date and time is required. Initialing the syringe label is also not required because the person who draws up the medication should be the same person who administers it. If this is not the case, then a person-to-person handoff of the medication is required. There has been a recent Texas case where one person prepared the syringe and mislabeled it, then gave it to provider number 2 who administered it without a handoff. This slide reviews the issue of medication handoff. Remember that if a provider is giving a break to another provider, medication handoff is required. Medication costs are always on a hospital administration's mind. The cost of neostigmine and glycopyrrolate total to about $3. The cost of Sugamidex is $136 according to some pharmacists. Obviously, in order to use such an expensive medication, the hospital will develop administration criteria. Accurate documentation of meeting the criteria is required. Actions may occur if this drug is routinely used unless it is approved by the hospital. There is also the issue of improper preparation. It is considered dangerous to use single-dose vials, one without preservatives, in a multi-dose manner and can be cited as an immediate threat condition. Infusions must be compounded by pharmacy unless there are extraordinary circumstances. If this occurs, the provider-prepared infusion should be replaced by a pharmacy-prepared infusion as soon as possible. The biggest offender is Pitocin, which is added to remaining IV fluids. Multi-dose vials were intended to be used on multiple patients. If the vial is closed, the beyond use date is that which is printed on the product label. Otherwise, generally, an open multi-dose vial expires in 30 days unless otherwise stated. Actually, contamination is more related to the number of times the vial was entered rather than the date or time, but no one surveys it this way. Most hospitals now consider multi-dose vials as single-dose vials. The risks are simply too high to think otherwise. Issues related to single-dose vials are very high risk at survey. In this slide, we address the issue of diversion and abuse. Diversion is really the theft of medication intended for use by others or for sale. Diversion is very hard to detect because most likely the diverter will have a clean urine drug screen. Abuse is self-administration of controlled substances. Anesthesia has a high rate of substance abuse, so particular attention must be paid to this potential. The reason is that this situation can destroy not only careers, but also lives. Recidivism is very high, and the wisdom of placing a recovering addict back into practice is controversial. Fentanyl and ketamine are the highest drugs of diversion and abuse. This slide demonstrates the problem with dealing with abuse. Urine drug screens are notoriously inaccurate for fentanyl. Those with substance use disorders must be treated. Diverters should be dealt with through the legal system. This ends the presentation. I hope that this has been helpful to you. Please feel free to contact me through email at the address on the screen, and thank you for listening.